Have you ever glanced at a medical chart or like an x-ray report and seen this massive complex word ending in megaly and just felt your heart rate instantly spike?
Oh, I mean, it is a completely terrifying moment for a lot of patients. You see a multisyllabic Greco-Latin term pop up on a portal message, and it just triggers this immediate doom spiral.
Right, because your brain assumes that the length and complexity of a word must correlate directly to, the severity of the disease.
Exactly. It sounds so official and terminal.
Well, today's deep dive is really about disarming that exact moment. We are demystifying one of the most common, yet honestly most misunderstood suffixes in all of medicine, which is megaly.
It's everywhere in medicine,
It really is. So our mission today is to give you a shortcut to understanding what doctors actually mean when they say an organ is too big.
which is more complicated than it sounds.
Oh, for sure. We're going to break down the mechanics of enlargement, the optical illusions that actually trick modern medical machinery, and the really profound way that naming a condition completely changes how humanity treats it.
Yeah, the history on this is fascinating. But to start, the foundation of this entire concept rests on the ancient Greek adjective megas, or megale.
Meaning great or large, right? Like magnitude.
Right, exactly. So when modern medical terminology formalized, doctors basically took that root and just started attaching it to the names of specific organs.
Kind of like building blocks.
Precisely. So you put cardio for heart with megaly, and you get cardiomegaly, an enlarged heart. Hepatomegaly is an enlarged liver. Splenomegaly is an enlarged spleen. Megalocephaly, an enlarged head.
I mean, on paper, that seems brilliantly tidy. Organ plus megaly equals organ too big.
It does seem simple.
Mm-hmm.
But assuming that naming the enlargement is the same thing as diagnosing the illness is a trap.
A huge trap.
Yep.
Because megaly is a purely descriptive term, it's not a diagnostic one.
Exactly. It is a finding, not a disease.
It's essentially the check engine light in your car. Like when that little light pops on your dashboard, it alerts you that a sensor has detected a problem under the hood somewhere.
Right, but the light itself doesn't tell you what's actually broken.
Exactly. It doesn't tell you if you have like a loose gas cap, a blown transmission, or if you're just out of oil.
So if a physician just stops at the word hepatomegaly, they haven't actually solved the case. They've merely acknowledged a clue.
Because the liver could be enlarged for a dozen different reasons.
Oh, easily. I mean, it might be enlarged because it's choked with fatty infiltration,
Mm-hmm.
or it could be distended from a viral infection, like hepatitis.
Oh.
It could be packed with malignant tumor cells, or even congested just because a failing heart is causing blood to back up into the hepatic veins.
So the hepatomegaly is just the physical finding. The underlying mechanism is the actual disease you have to treat.
Precisely. Relying on the megaly as an answer rather than using it as a question is really dangerous clinical practice.
But, if megaly simply denotes that something is abnormally large, that assumes we have this ironclad definition of what normal actually is.
And we don't,
Yeah.
because humans aren't stamped out of a factory mold with identical specifications.
Right.
That tension over defining normal is actually driving a massive shift in radiology right now. Historically, the thresholds were incredibly rigid.
Like just the strict number on a chart.
Yeah, take the spleen, for example. For decades, the standard rule was that if a doctor could physically palpate or feel the spleen below your rib cage, or if it measured over 12 to 13 centimeters on a CT scan, boom, you had splenomegaly.
Wait, but if I have a 13-centimeter spleen and I'm, say, a petite 5'2", that organ is taking up a disproportionate amount of my abdomen?
Exactly.
But if a professional basketball player who is 6'10" has that exact same 13-centimeter spleen, I mean, it's just proportional to their body.
it's totally normal for them.
So calling both of those megaly based on a static number isn't some objective physical law. It's just a highly subjective, kind of flawed interpretation.
It is flawed, and the medical community is finally recognizing that flaw and moving toward what we call population-adjusted norms.
Okay, meaning what exactly?
Meaning radiologists are increasingly factoring in things like height, sex, and body surface area before stamping a megaly diagnosis on a chart.
So the context of the human carrying the organ dictates the pathology.
Exactly. And context also involves distinguishing between a healthy adaptation and a dangerous defect.
Oh, like athletic heart syndrome.
Yes, perfect example. Think about a marathon runner or an Olympic cyclist.
Right, they undergo years of grueling endurance training.
And because the heart is a muscle, it adapts to that workload by growing larger and stronger.
But a sports cardiologist looking at that athlete's hypertrophied heart wouldn't label it cardiomegaly, would they?
No, they wouldn't, because the suffix megaly carries a very specific implicit judgment in medical vernacular.
It implies that something has gone wrong.
Right. It doesn't just mean a structure has increased in mass. It means it has increased in a way that signals failure or disease. The athlete's heart is a physiological triumph. Megaly implies a pathological breakdown.
So, to understand why modern medicine relies on an ancient Greek word loaded with such heavy clinical judgment, we kind of have to look back to the 18th and 19th centuries.
Yeah, medicine was undergoing this massive maturation process during that time.
Because prior to this era, disease naming was just a chaotic mix of regional vernacular and, like, superstition.
Oh, it was all over the place. You'd have these really vague, descriptive diagnoses like the sweating sickness or the ague.
EEG, right. Just totally useless for sharing information.
Exactly. But as pathology developed and physicians began routinely examining organs directly through autopsies, they desperately needed a systematized, internationally legible language.
Like botany and anatomy already had.
Yes, they were already utilizing Greco-Latin frameworks as a universal scientific language, so medicine adopted that same exact toolkit to categorize human suffering.
And the power of that taxonomy is just perfectly illustrated by this French physician, Pierre Marie, in 1886.
Marie is a legend for this.
Yeah, he was observing a cluster of adult patients who shared this strikingly specific pattern of physical changes.
They had profoundly enlarged hands and feet, protruding jaws, and these heavy, thickened brow ridges.
And crucially, these bone changes were happening in their 20s and 30s. So long after normal skeletal growth should have concluded.
Right. And before Marie's clinical categorization, society just treated these individuals as aberrations.
They were basically relegated to sideshows, right?
Sadly, yes. They were labeled as giants or oddities and pretty much entirely dismissed by the medical establishment. They were viewed through a lens of spectacle, not science.
But Marie completely flipped that paradigm. I mean, he coined the term acromegaly,
Taking the Greek word akron, meaning extremity.
which is the same root we use in acrobat or acronym, right?
Exactly.
Yeah.
So akron plus megas for large. Enlargement of the extremities.
And by doing that, he proved this wasn't a collection of random mutations or a mystical curse, but a single coherent medical entity with a shared biological cause.
And honestly, the psychological shift that word initiated just cannot be overstated.
Because it gave them legitimacy.
Exactly. By giving the condition a formal, systematized Greek name, Marie reclassified these individuals. He moved them from the category of circus freak into the category of patient.
Wow. It forced the broader medical community to take their suffering seriously.
And eventually, to search for a treatment.
That breakthrough really opened the floodgates for 20th century medicine to adopt the megaly template for everything. But Pierre Marie's specific focus on adult patients with acromegaly highlights a really common misunderstanding about how human bone growth actually functions.
It does, because acromegaly is almost always driven by a benign tumor on the pituitary gland at the base of the brain.
And this tumor basically acts like a rogue factory, right? Just constantly secreting excess growth hormone into the bloodstream.
Yes, but the specific physical manifestations of that massive hormone dump depend entirely on timing.
Right, it all comes down to the growth plates or the epiphyses at the ends of your long bones.
Which is such a crucial distinction.
Yeah, so in late adolescence, those plates fuse, right? They turn from soft cartilage into solid bone.
Right. So if a pituitary tumor starts pumping out excess growth hormone before those plates fuse, say, when a patient is like 10 years old, the long bones can still lengthen.
So the legs get longer, the arms get longer, resulting in extreme rapid vertical height.
Yes, and that condition is called gigantism.
Okay, but when the tumor develops after the growth plates have fused, the mechanics change entirely.
Entirely. The hormone is still flooding the system, demanding that the skeleton grow. The osteoblasts, the cells that build bone, are highly stimulated.
But because the plates are sealed, the bones physically cannot get longer.
They have absolutely nowhere to go vertically.
It is like pouring wet concrete. Like if you pour concrete into a flexible rubber tube, the pressure pushes the ends out, the tube stretches and gets taller. That's gigantism.
That's a great analogy.
But once those growth plates fuse, it's like you've replaced that rubber tube with a rigid, sealed steel box. You keep pouring concrete in, but the box can't get taller. The pressure just forces the concrete to pack denser, thicker, and wider.
Exactly. So with nowhere to go vertically, the bone matrix expands horizontally. soft tissues multiply too. And this is acromegaly.
And because bone remodeling in adults is just such a slow, methodical process, the visible signs unfold incredibly gradually.
Oh, incredibly slowly.
Yeah.
We're talking about an average diagnostic delay of 7 to 10 years.
So, a decade of excess hormone before anyone catches it?
Yeah, because a patient will slowly notice, well, maybe their wedding ring no longer slides over their knuckle, or their shoe size creeps up a half size.
And the lower jaw continues to grow forward, creating that severe underbite known as prognathism.
But it is so gradual that the patient who is looking in the mirror every single day rarely registers the transformation.
Right, it's the boiled frog effect. It's often a family member looking at a photograph from a decade prior, or like a dentist wondering why a patient's bite alignment has radically shifted in their 30s, who raises the alarm.
That's usually how it happens, yeah.
Yeah.
And this timing distinction also clears up the rampant mediumist labeling of famous historical figures.
Oh, right, like Andre the Giant.
Right, he is the most recognized case, and he actually experienced both conditions sequentially.
Because his tumor started early.
Yes, his pituitary tumor developed in childhood, driving the extreme vertical growth of gigantism. But because the tumor was never removed, it just continued pumping out growth hormone well into his adulthood, long after his plates fused.
So that caused the classic acromegalic facial and hand thickening we see in later photographs of him.
Exactly. He had gigantism that transitioned into acromegaly.
Conversely, look at Robert Wadlow, the tallest man in verified recorded history at 8'11". Media articles frequently and incorrectly label him as having acromegaly.
Which is medically inaccurate.
Yeah, Wadlow's condition was purely gigantism. The hormone excess acted while his plates were open, driving vertical height without the dense, distorted horizontal thickening seen in adult-onset acromegaly.
They are the exact same hormonal dysfunction, just playing out under different mechanical constraints based on human developmental stages.
Now, while bone density takes a decade to reveal the effects of a rogue hormone, soft tissue organs operate without those rigid skeletal limits, right?
Oh, absolutely. Soft tissues can swell rapidly, introducing immediate, acute physical dangers.
And the spleen is sort of the perfect example of how splenomegaly transforms a silent organ into a mechanical hazard.
Right, because the spleen acts as the body's primary immunological filter. It screens the blood for old red blood cells and fights off pathogens.
And because it is a downstream filter, it swells in response to a massive array of upstream crises.
Right. If you contract infectious mononucleosis from the Epstein-Barr virus, the spleen swells as it produces white blood cells.
Or if you contract malaria or have cirrhosis of the liver or suffer from sickle cell disease, right?
Yes. The spleen acts as a sponge, engorging itself with trapped cells and fluid.
Now, a normal spleen is soft, spongy, and tucked safely high up under the rib cage on the left side of the abdomen.
It is heavily protected by the skeleton.
But as splenomegaly sets in, the organ engorges. It descends below the protective cage of the ribs, protruding into the vulnerable soft tissue of the belly.
And more alarmingly, the outer capsule wrapping the spleen is stretched paper thin.
It loses its elasticity. It essentially becomes a taut water balloon.
Which creates a life-threatening vulnerability. I mean, a minor blunt force trauma like a seatbelt locking tightly across the abdomen during a minor fender bender or standard tackle in a high school football game can easily rupture that hyperstretched capsule.
And a ruptured spleen causes massive, rapid internal hemorrhage.
Yes, this is the exact mechanism behind youth sports return-to-play protocols.
Right. When a teenager gets mono, pediatricians strictly forbid contact sports for weeks or sometimes even months.
The clinical debate isn't just about the virus clearing the bloodstream. It's literally about waiting for that physical capsule to shrink back to a safe thickness and retreat behind the ribcage.
That makes total sense. Now, cardiomegaly presents a completely different mechanical puzzle for doctors, largely because the heart size is so often evaluated indirectly through two-dimensional imaging.
Right, chest x-rays. Radiologists calculate what's called the cardiothoracic ratio.
Which is what exactly?
So if the width of the heart shadow exceeds 50% of the total width of the inner chest cavity, they flag it as cardiomegaly.
But again, this is a descriptive finding that demands mechanical investigation.
Always.
Because a heart shadow might be wider than 50%, because chronic high blood pressure forced the heart muscle to thicken to pump against that resistance.
Right. Or a massive heart attack could have killed off a section of muscle, causing the remaining heart wall to dilate and stretch out like a blown-out tire.
Oof. Or The heart muscle itself might be perfectly normal in size, but the pericardial sac surrounding the heart has filled with fluid.
The pericardial effusion.
Exactly. And on an X-ray, the fluid and the muscle share the same density, so they merge into one massive white silhouette.
So the heart isn't actually enlarged, it is just sitting inside a swollen water balloon.
It's an illusion. And speaking of illusions, the most fascinating element of cardiomegaly diagnosis is the artifact debate.
Oh, this is huge in radiology.
The fact that the physical positioning of the X-ray machine can literally lie to a physician, creating a false megaly out of thin air.
Yeah, this happens daily in intensive care units. So in a standard outpatient radiology suite, you stand up against a film plate. The X-ray beam hits your back and travels anteriorly to the plate on your chest.
This is a PA, or posterior to anterior film.
Right. And because your heart sits in the front of your chest, it is physically very close to the film plate.
But if a patient is critically ill and bedridden in the ICU, the technicians bring a portable X-ray machine to the bed.
Yes. The plate slides under the patient's back, and the machine shoots the beam from the ceiling down onto their chest.
So this is an AP, or anterior to posterior film.
Exactly. And in an AP film, the heart is far away from the film plate, beneath the patient's back.
Okay.
So as the X-ray beams pass through the heart and travel the distance down to the plate, the beams diverge. They spread outward.
Oh, wow. So is this exactly like making shadow puppets on a wall?
It is the exact same physics, yes.
Like if you put your hand an inch away from the wall, the shadow of the rabbit is sharp and matches the actual size of your hand.
Right.
But if you pull your hand back and hold it right up against the flashlight, the beams diverge wildly, projecting this massive, distorted monster shadow onto the wall.
That's exactly it. The portable AP X-ray artificially magnifies the cardiac silhouette, tricking the cardiothoracic ratio and leading to a totally false diagnosis of cardiomegaly.
That is wild. So with so many different underlying causes, from hormonal cascades to actual optical illusions, it becomes crucial to separate megaly from other specific medical suffixes that define how an organ is growing at a cellular level.
Yes, we have to differentiate size versus quantity.
Okay, so take the suffix trophy as in hypertrophy.
Right. Hypertrophy describes a change in the physical volume of the individual cells.
Like if you lift weights, your muscle cells undergo hypertrophy, the cells themselves swell up.
Exactly. And that requires a completely different clinical intervention than the suffix plasia, which denotes an increase in the number of cells.
So benign prostatic hyperplasia means the prostate is enlarging because the cells are rapidly dividing and multiplying.
Right. Both hypertrophy and hyperplasia result in the gross anatomical finding of a megaly. But treating a cell that is swollen requires a fundamentally different pharmacological approach than stopping a cell from replicating.
The same logic applies to causality suffixes too. Like oma denotes a tumor, anitis denotes inflammation.
Right, so a liver cancer can cause hepatomegaly. Hepatitis, a viral inflammation, can also cause hepatomegaly.
The tumor and the immune response are the active mechanisms. The megaly is merely the physical consequence.
And interestingly, this descriptive power is so resonant that the vocabulary actually crossed over from physical pathology into psychology.
Oh, you're talking about megalomania.
Yes. The psychiatric term megalomania utilizes the exact same ancient Greek root. But instead of describing a physically distended organ, it describes an inflated, grandiose pathological expansion of the ego and self-image.
That is such a fascinating linguistic leap. And it perfectly illustrates the core misconceptions we really need to dismantle here.
Right.
First, seeing a megaly on a chart does not default to cancer.
Not at all. Malignancies are far less common culprits than simple infections, temporary inflammation, or just localized fluid congestion.
Second, an enlarged organ on a scan is not definitive proof of disease, as we saw with the endurance athlete's heart and those shadow puppet portable X-rays.
Context and biological variation completely dictate the diagnosis.
And finally, it names the sign, not the disease.
And that's the psychological danger for both the patient and the physician. Human psychology craves an immediate answer.
Oh, for sure.
Slapping a complex Greek suffix on a finding provides this false sense of closure. It feels like you've captured and categorized the illness.
Like Marie did, it feels like you solved it.
Exactly. It takes strict clinical discipline to acknowledge that the impressive word is just the first breadcrumb on the trail to the actual culprit.
Which is why understanding this vocabulary provides immense agency to you, the patient.
Oh, absolutely. Abdominal palpations for the liver and spleen, and routine chest x-rays to check the cardiothoracic ratio. These are some of the most frequent screening tools in modern medicine.
You will inevitably encounter these terms in your own medical records at some point.
And knowing that acromegaly unfolds over a decade empowers you to notice the subtle clues.
Right, the tightening rings, the shifting dental alignment. You could potentially save yourself or a family member years of delayed intervention.
It just strips the terror out of the medical chart.
It really does. When you see megaly, you aren't looking at a death sentence. You are just looking at biological data. You are looking at the check engine light.
It remains a signal that biological enlargement has crossed a threshold into pathology. It is a physical manifestation of a system that has lost its regulatory limits.
Which honestly leaves us with a really provocative final thought for you to chew on.
Yeah.
In our model culture, we are thoroughly obsessed with the concept of unchecked expansion. I mean, we demand bigger houses, we expect our businesses to scale relentlessly quarter after quarter, and we constantly push to maximize our output at all cost.
More is always better.
Right. But this medical suffix serves as biology's stark reminder that there is a profound difference between growth and health.
That's so true.
In the human body, perfection isn't found in relentless, unconstrained expansion. It is found in strict, delicate, meticulously maintained balance.
Too much growth is literally pathology.
Exactly. Which forces us to ask, at what point does our societal drive for infinite scale become its own form of cultural megaly? Something to think about the next time you see a check engine light pop on.